And okay, we're going to have vaccine strategies and pregnant for the protection towards the first child by Dr. Ingrid Lechan. This is going to be coordinated by Dra. Castro and Dra. Analias Diaz Rosino, a pediatrician and a founding member with ASAPNEO, with a training in neurodevelopment, kangaroo method, and public health, president of the Pediatric Association of Guatemala. Thank you so much for all the people that stayed until the last moment. And therefore, I'm going to. And then the Ingrid Lizama is a pediatrician from El Salvador, and it's the current association of El Salvador. And we have the pleasure of welcome her for the closure of our conference. Good afternoon, everybody. The truth is that right now we feel a bit tired, but we're about to finish. It's very important. I think that this talk is a very important talk. It's going to be a summary of everything that we've been listening to in this wonderful conference. That's why let's continue. And what are we going to talk about? We're going to talk about the double shield. We can see the signs of maternal immunization. And we need to understand the mechanisms, the clinics, and the challenge to be able to protect two lives with just one single strategy. And the goals, it's going to be to understand the role of maternal immunization in maternal and neonatal health. We want to review the vaccines during pregnancy, key concepts of vaccination during pregnancy, current recommendations, and also the new and future vaccines for maternal immunization. And we need to start talking about the double vulnerability that there is in between the mother and the fetus. We can say that in the mother, we still know that there are immunological changes and that the pregnancy requires an immunological adaptation that increases the risk of infections, the risk of both viral infections as well as bacterial infections, and that there is an immunological immaturity because the fetal system presents a biased response towards the T lymphocytes and an inability to be able to understand an adequate response to antibodies. That's why a maternal immunization closes this gap, offering one of the most successful healthcare interventions that we currently have. And here, what we are interested is to see that 70% of children, the mortality happens in children that are under 5. And we've done studies where we want to determine that 50% of them are deaths during the neonatal period. This is why, when should we vaccinate pregnant ladies? We can see that the mothers has a high level of record to the disease, that the disease means a special risk and to the mother, and that this is a very specific risk for the fetus and for the newborn, and that there is a vaccine that it's available and that it's unlikely that it causes harm. That's why we study the risk and benefit, and it and we can see that the risk to being ill is higher than the risk to being vaccinated. And we can see that the biological bridge and also the immunological transfer, what happens? We can see that one of the first one is the active transition. That it's the passage of the IgG antibodies of the mother to the fetus. And we can see that the neonatal receptors mediated the active transfer of IgG. Basically, IgG-T in this process accelerates significantly after the 32 weeks of gestation. And we can see that this has an average life at 28 or 35 days of life, which can surpass even 6 months. This mechanism is the cellular microchimerism, which is the transfer of maternal lymphocytes, more or less memory cells that are detectable in the umbilical cord blood. The third mechanism that we have available is innate immunology, um, that happens in the fetus. And we can see that there's an exposure to maternal cytokines and antigens that train the innate immune situation. And the fourth thing that we've been talking about, which is breastfeeding, which is very important to be taken into account. You can see that it's the fourth mechanism that protects the newborn. Here we're going to talk about the prevention through the antibodies of breast milk. You can see that breast milk is associated to the immunity of the mucosa. This leads to a reduction of the incidence of diarrhea and respiratory diseases, a lower long-term risk of developing asthma, allergies, eczema, atopic dermatitis, diabetes, and also inflammatory diseases. It's especially relevant in environments where there are limited resources and where diarrhea and malnutrition are common. But we do know that we need to, as the neonatologist insists on breastfeeding, because it's essential for the defense of our newborns, and we can see that a droplet of milk, all what it can give us, and we can see very specific protections, and therefore there's a huge reflection of IgI and AgG, and we can also protect it against pneumococcus, influenza, and therefore interstitial respiratory diseases, hypercoccus and hypertusis. There's a little bit about the history, and therefore of we need and therefore we can see that the immunizations with the vaccines of measles protected both the mother and their kids. And in 1994, we did immunization studies with the DPT vaccine in the U.S. to be able to protect the babies against whooping cough. In 1970, the vaccine against influenza was recommended for pregnant ladies at risk, and this was because of the pandemic of 1957. And we can see that immunization with titanium toxoid to avoid neonatal tetanus was included to the expanded immunization program of the World Health Organization. And therefore, we can see that we established a way to eliminate neonatal tetanus. And therefore, we can see routine vaccine started with to polio, and we can see that therefore the FDA prohibited the pregnant ladies who would be part of clinical trials with medications. But we can also see that the vaccine that there was a benefit in vaccinating pregnant ladies, and this was shown in between the 70s and the 80s, because there was an outbreak of polio in Finland, and there was an outbreak of meningococcus in Brazil. The influenza H1N1, we were able to see the risk of infections in pregnant women, and also we were able to see the benefits of immunizing pregnant women. We could see the coqueluche outbreaks between 1812 and 20. We were able to see that increased the risk. And we also see the increase of applying the TIP vaccine to a pregnant woman. Thus, what are the vaccines that should be applied to all pregnant women? We all do know that we need the vaccine against influenza, the vaccine against the VCR, RCV vaccine against COVID, and also the vaccine against the TDIP to protect against whooping cough. Many people say 2+2, two in each arm, and this is a motto that it's used a lot. The vaccination strategy during pregnancy that we already mentioned, the four recommended vaccines. We have vaccines that have been used in very specific risk situations, and this is also that has happened in those areas where there has been cholera, yellow fever, meningitis, hepatitis, Japanese encephalitis, polio, and rabies. And we can see neonatal tetanus. There were 4 lines to be able to reduce tetanus, because we do know, because when you studied in July 2019, 12 countries had eliminated neonatal tetanus. That's why they implemented the immunization of the pregnant woman, the immunization of women in fertile age with at least 2 dosages of anti-tetanus vaccines to reinforce the surveillance of neonatal tetanus and to improve conditions during pregnancy. And therefore, what we want to show is that when we implemented the 2 dosage vaccinations of vaccines against tetanus, we were able to reduce the mortality through by neonatal tetanus. As is the vaccination against pertussis. It was recommended by WHO since 2015, by the CDC since 2012, and also recommended by the Society of OBGYNs since 2020. We have done studies, and the thing that we were able to verify, it's the effectiveness and the prevention of whooping cough in babies up to 91% of the cases, the prevention of hospitals case in 85% of the cases, the prevention by whooping cough in almost 95% of the cases. We can say vaccinations against whooping cough during pregnancy had a risk benefit ratio that was positive. Let's be mindful that babies below 2 months of age have the highest rate of whooping cough, and that 77% of the babies under 2 months with whooping cough need hospital treatment. But not only that, we can also see that they can also have complications, and there can be a mortality of almost 14% in children below 6 months of age. In the prematures, we were able to evidence that, but it's the term baby, and that the complications, right, we would like to have a higher hospital rate, higher mortality rate, lower compliance to the vaccination recommendations. And this is when we already implemented vaccination. We can say that we were able to reduce whooping cough infections in babies under 2 months. We can see that these are the babies that are vaccinated below 6 months. Once this was implemented, they're in babies under 2 months of age. And therefore, just to remember that the prevention of whooping cough in a baby, it's almost 91%, and the prevention of hospital stays almost 94%, and also the prevention of mortality by whooping cough 95%, and also that the benefit has been high. And therefore we can see how we reduced the deaths in under 1 year. And in countries like Argentina, we were able to try to reduce, in Brazil 50%, in Colombia 75%, in Salvador, and in Uruguay 90%. This is very important in mentioning, which is the effect of the blunting interference versus clinical protection. We were able to create them with vaccinating a pregnant woman when the baby was born. We can see that those antibodies that had transferred to the fetus were going to interfere in the vaccination of the newborn. But throughout the studies, we were able to evidence that that's not the case. That this immunological interference, that the involvement was just transitory, and that the immediate clinical protection was was a feasible advantage. That's why in the clinical consensus, maternal immunization doesn't involve the long-term clinical protection of the baby. The immediate survival surpasses the transitory interference. We just to remember that the effectiveness of the of babies under 3 months of days because of pertussis, it has a protection 94 and reduces death by pertussis in 95% of the cases. When we talk about RSV, we can mention that we can say that during the 3 months of life, this is where we can have higher rates of complications of acquiring the virus. That if the baby moves forward in life and in months, we're going to see that there can be an infection, but the probability is lower, and the complications are lower. And during the first 3 months of life, we're going to see the highest incidence rate. One vaccine we've talked a lot about the RSV. We saw that there was a balanced neutralizing effect when compared to groups IA with the bivalent vaccine based on protein F in a perfusion state. We wanted to say that that in Buenos Aires, and the idea is to have a bivalent vaccine that has had an effect in the protection, and both subgroups are the ones that are associated to severe diseases. The vaccines against the RSV, this is the vaccine that was studied for pregnant women, and that's and for the newborn. And therefore, we can get to the baby during the first 3 months with an 82.4 protection rate, and that at 180 days, that it means that it's almost 6 months. We can see that protection drops, but it's still 70%. In Europe, in August was implemented in Europe as well, which is for the immunization of pregnant women, and the protection of the newborn during the first 6 months of life. That in Europe we implemented it from the 24 weeks of gestational age on 36, and from the United States from 32 to 36 weeks. And in several countries, they have adopted applying it after 28 weeks of life. As a matter of fact, in my country, we applied at 28 weeks, and we've had very good outcomes. And in the countries where we've applied it at 28 weeks, there was a study that I'm going to present later on, where we showed the adverse effects, and that we saw in prematurity that it's the most significant thing, which is what no differences between the adverse effects because the ones that were observed was preeclampsia, and this was not significant. That's why it was discarded, and that at the onset we were able to observe prematurity. But as we were moving forward in the application of these vaccines, that the country that decided to apply it at 24 weeks of gestation age, were able to see that in practice this is something that wouldn't cause it, that they needed to be more careful and like assessing pregnant women to be able to see this situation. And okay, we can see that Moderna vaccine it's approved in more than 50 countries. We can see how it operates worldwide. So, in Argentina, we have seen this study where we can see the efficacy of the vaccines for pregnant women had a 78.6% of a reduction in hospital stays in babies from 0 to 3 months, and 71.3% in hospital stage from 0 to 6 months, and 71.9% in hospitals in very severe hospital stays in babies between 0 and 6 months.
Regarding COVID vaccine, even though many countries are applying, but it's important to consider that there's still COVID worldwide. Even though the cases have been reduced, but we all know that the pregnant woman with COVID will have terrible outcomes in her health and the fetus, and that really leads to preterm deliveries and death. So we cannot forget this vaccine, and important to remember that a booster uh, vaccine is related with 56% of reduction on the risk of infection in the first 6 months of life of the babies compared with babies of mothers that were not vaccinated. This was seen during the period where Omicron was predominant. Anti-flu, okay, the flu vaccine, you can see clear protection during pregnancy, after pregnancy, and it has around 60% that the newborn has protected, and that really this protection is before 2 months of age. So this is important to administer the vaccine of influenza, because the vulnerability of the pregnant woman can lead her to other complications and lead her to hospitalizations. We've all seen pregnant women intubated in an ICU due to H1N1. We can see efficacy, the protection of 53%. Okay, the roadmap, gestational roadmap for immunization would be that the influenza flu vaccine, inactivated vaccine, and vaccine our ARN messenger can be applied in any quarter during the pregnancy. The TDAP, meaning started in the weeks 27-36, were recommended around 20 weeks of gestation. Vaccine applied for the pregnant woman against the respiratory syncytial virus. The indication is between 32 and 36 weeks, and actually some countries administer since the 24 weeks of gestation. In summary, we can confirm that the vaccines are effective. The flu vaccine is an activated recombinant COVID-19 ARN messenger, TDAP, toxoides, and cellular pertussis, and also RSV, protein F, or stabilized perfusion. What are the vaccines that are not indicated in the pregnant women? Triple viral. That would be these three: smallpox, also chickenpox, BCG against tuberculosis, and
Ese
intranasal
contiene el
influenza
virus.
because it has live
Ahora, usted
viruses.
tiene que
Now, this
informar
is very important to consider.
cuándo se
If by
toman estas
mistake you
vacunas. La
apply some
vacuna
of these
embarazadas,
vaccines to a
esto no
pregnant
es
woman,
indicación de detener el embarazo,
this
sino
is
se
not
debe de
indicative
seguir una
of stopping
estrecha
the pregnancy,
vigilancia
but we
a
need
la
to
mujer
follow
embarazada.
up on that pregnant woman, to follow up. So,
Entonces, ¿cuál
what
es el gran
is
problema?
the
¿Por qué
important
aún en nuestros
problem? Why is
países,
it in our
no solo en
countries,
América
not only
Latina, sino
in
que a
Latin
nivel
America,
mundial,
but at worldwide
no se
level,
logran
we are not
coberturas
able to cover these
reales,
schedules, the
la
ideal
cobertura que
schedules,
espera la
the coverage
Organización
that
Mundial
the
de la
World Health
Salud, que
Organization
es la cobertura
expects,
que
or
cada uno
PAHO,
de
that the
nosotros
coverages
espera
that we
para
expect
asegurar esa
to make
protección
sure that there's
y disminuir
total
estas
protection to reduce
infecciones que
these
son
infections
prevenibles.
that can be
Bueno, el
preventable.
gran problema
Okay,
es
the important problem
la
here
gran
is the barrier,
desconexión que hay
the
entre
disconnection
la
that is
eficacia
between
comprobada
proven
y
efficacy
que hay una
and
cobertura
there's
insuficiente.
not enough coverage.
Estos son datos que
So
aún
this
en
is data
Italia,
that
pero
still in
todavía
Italy, the variable
también
coverage
en
is
Francia
critical.
tienen hasta un
Flu
19%
6
de
until
vacunación,
19% of
protección
vaccination,
62
pertussis up to
y COVID
61%,
un
and COVID 19
20%.
20%.
Irlanda influenza
Ireland influenza
62%, COVID
62%, COVID 19
25%
25% in Ireland.
y Estados
And
Unidos
United States
10% de
has
cobertura.
these coverage.
A pesar de las fuertes
Even though there's a
recomendaciones de la
very strong
Organización Mundial de
recommendations by
Salud,
World
la
Health
inmunización
Organization,
materna
maternal
sigue siendo
immunizations continues to
subutilizada a
be
nivel mundial.
not
¿Por qué la
underused at a
ciencia
worldwide
no
level.
está
Why
llegando
isn't
a todos los
science arriving
pacientes?
to all the patients?
Bueno,
Well,
por esto,
due to this.
el famoso embudo de la reticencia vacunal.
This would be what we call the funnel,
Ausencia de percepción de
the
riesgo.
absence of risk,
Hay
perception of
entre
risk.
25 y
It says
39%
between 29
de las
39% of
mujeres
the women, they
desconocen
don't
las
know
iniciativas de
the
vacunación
vaccination
o
initiatives
ignoran
or
la
ignore
susceptibilidad de
their
ellas
own
a complicaciones por influenza o por gripe.
susceptibility to complications due to flu or
El miedo y
pertussis.
la desinformación.
Fear and
El
misinformation. 29%
29% cree
believe
erróneamente que las
wrongly
vacunas
that
pueden
vaccine
dañar
may
el
damage
desarrollo
the
fetal.
development of the fetus.
El 18% duda
18%
de su
are
efectividad.
doubting about its
Y el
own
miedo a los
effectiveness, and the
recipientes
fear
es
to
un factor
excipients
primario
is
de
the
rechazo.
primary factor of rejection.
Preconcepciones de vida, bueno,
The
creen que
ideas
las
of life, they
vacunas
believe
solo
that the
son para
vaccines are
niños
only for
y que no
children
son
and that are
para
not
adultos
for
o para mujeres
adults nor
embarazadas.
pregnant
Entonces
women.
el
So the
resultado
result or the outcome
se rompe el
is
escudo.
we break the shield.
Entonces encontramos un punto de
So we
inflexión,
have an inflection
la
point,
recomendación médica.
the
Ahí
medical
nosotros los
recommendation.
médicos
So
jugamos un papel
we
importante
are very
porque
important in this case
neonatología
because
hablando de
neonatology,
vacunas
talking about
generalizadas,
vaccines in
porque
pregnant women,
sí,
yes,
nosotros
because
desde
from
nuestros
our
hospitales,
own
desde
private
nuestros
practices,
trabajos privados,
hospitals,
nosotros
we
debemos de
should and
informar
must
a nuestras
educate our
pacientes,
patients,
a nuestras
our
madres,
mothers,
falta de capacitación en
because there's lack of
inmunología,
training in immunology,
dudas sobre seguridad
doubts
y
on
falta de
efficacy and
tiempo.
safety,
En
and lack of
efecto,
time.
las mujeres perciben que
So
la
the
vacuna
women feel
no
that the
es
vaccine is not
importante
important
porque es riesgosa.
or it may
Pero si
imply
nos
a
vamos
risk.
por la ruta A,
If
en la
we
ruta A se rompe el
choose,
escudo,
okay,
perfecto.
pathway A,
Por
we
la
break the
ruta
shield,
B,
but pathway
recomendación
B,
activa.
this could be an active
Causa
recommendation.
educación
It would
médica
be
continua
medical
y una
continuous
comunicación
education and
empática
empathetic
basada
communication
en
based
la
on
evidencia.
evidence.
Entonces el
This is
efecto
the
va a
cause.
ser
The effect will
que
be
las mujeres
that
sí van a
women
aceptar la vacunación,
did
¿verdad?
accept vaccination
Y su médico,
and
confíen en su médico.
they trust the doctor. The
¿Verdad? O el
gynecologist says
médico general
they need to
o
be
el neonatólogo
vaccinated,
o el
or
pediatra
neonatologist or
da una buena
pediatrician
educación a
gives
la
good
madre
information to
con
the mother
empatía,
with
vamos a
empathy,
lograr
we're going to
que
be
esa mujer
able
se
to
vacune
make
durante su
this
embarazo.
woman
Entonces
get
la
vaccinated during
recomendación
pregnancy.
explícita
Though
de
the
usted
recommendation of
médico
the
general es el
medical
predictor
MD
más
is the most
fuerte de
important predictor
aceptación de la
of
vacuna materna.
accepting the maternal vaccine.
Bueno, en el horizonte
Okay,
científico,
in
¿qué vacunas
scientific
están en desarrollo?
horizon,
En
what
fase
vaccines
uno
are
y fase 2
in phase 1 and phase 2. We have the problem is Streptococcus of group B. The problem causes sepsis, neonatal sepsis and meningitis. The innovation is a glycoconjugated hexavalent vaccine, covers 98% of the strains, and models suggest that it could prevent 127,000 cases through Streptococcus group B and 37,000 deaths of babies annually. Cytomegalovirus, CMV, the problem is infection, congenital infections and loss of hearing. Innovation, RNA messenger, ADN, live viruses, for the protection of the fetus. And we also have malaria under development as well. How important then is to vaccinate a pregnant woman? It's an intervention into lives. Maternal immunization goes beyond individual protection. It's the active transfer of survival. It's a biological bridge that ensures that no newborn baby will face their first months of life without any defense. So, integration of these vaccines in the routine prenatal care is fundamental for equality in health and the reduction of the global burden of infectious diseases. Thank you very much. Okay, any questions? You know the methodology, you can raise your hand and you can ask your question so that the doctor can answer your question. I will start by asking a question, which is, there's an interesting figure that is called prenatal consultation, where the family goes to assess things related to the future of that pregnancy. Do you believe that to promoting this pediatric consultation, could we increase that low coverage, at least in Latin America? Yes, I think that prenatal visit is very important. The fact, when we have a mother and it's your first patient and she's pregnant, the sad thing is to ask, how about your gynecologist? Did you say to administer the vaccine? And she says, no, he didn't say, or she didn't say anything at all. So in El Salvador, we try to promote, we incentivize the gynecologist because they need to support us in vaccinating the pregnant women and the mothers in this prenatal visit. The majority arrives with his partner, so her partner. So education, this moment is wonderful to be able to educate the women, to make them see the importance. And honestly speaking, there are some pediatricians that even they want to offer the vaccination if the gynecologist doesn't do that, or send them to the most important healthcare center in the country. For example, for this respiratory syncytial virus, is at a national level, the RSV. So this is very important. The flu vaccine, TDAP, and COVID, we all have access to these vaccines. And I do believe that the prenatal visit, yes, could be let's say, increase awareness of the pregnant women that must be vaccinated. Yes, I was speaking with Sergio. It's very frequent when we go to the visit for the first time with the baby, newborn baby, and we start to question the women regarding the vaccine. She says, "Okay, no, I haven't taken them," or when they are in the second pregnancy, and they say that if they need to apply or administer the vaccine. And also, we need to think of the vaccination of the parents, not only the mothers, but also the fathers. They can also, if really, they can spread the disease to their own babies. So we need to work on this. I think pediatricians, we have the vaccines chip installed. And we do that. Not sure if the other professions have it, or the medical professions, at least in Argentina. We still need to work a lot harder in this.
se ha visto, ¿verdad?
We've seen that the
Los
pediatrician,
médicos
neonatologists, and infectologists,
recientes a vacunar a
we are
niños y
prone to
embarazadas
vaccinate the
a los de
pregnant
nacida y
women,
a
the
los
newborn
niños.
babies, and the
Y los
children.
obstetras pues tenemos que por eso
So
incentivarlos, que
that
nos
we
apoyen,
that's we
porque de
need to
repente
do that. We
lo
need that
usted es
support.
cierto y uno se atreve a ponerle
And we even dare
a
to
algunas
administer the vaccine.
enfermeras.
If the
Lo,
obstetrician
porque antes
doesn't
usted
do it,
tenía
I
hasta
will do it, because
dermatólogo, de
before
todo,
being
uno ha sido médico
infectologist, we've
general.
been a medical
Entonces sí
doctor
podemos
or a
tener esa
general doctor.
experticia
So
de poder vacunar
we have the
a las
experience to be able to
embarazadas, que no
vaccinate the pregnant
debemos de
woman,
perder
because we
esa
cannot
oportunidad.
lose sight of that opportunity.
Bueno, yo agradecer, muy interesante.
Thank you very much. Very interesting, this talk. It brings a
No se asusten,
topic.
pero ya estoy
Don't
pensando.
be afraid of what I'm going to say, but I'm
Ahora,
already
esto lo
thinking. For the next
empiezo y lo
Congress,
pienso
I
hacer
promise
lo
that
posible para que
I
haya
can do whatever I
hombres
can to have
en
obstetricians
pediatría también.
among the
Porque
speakers.
fíjense,
Okay,
aumíntese,
so
son una de las
it's
partes
one of the most important
importantísimas
parts
de lo que nosotros como seguimentólogos proponemos, que son las
of that we
intervenciones para
propose
toda
the
la vida.
interventions throughout
Y
the whole life.
definitivamente la
And
protección
apart from
materna,
mother nutrition, prenatal
todo eso,
control,
el control
I think
prenatal
that
tiene que incluir la
prenatal
inmunización
control should
materna.
include the
Entonces,
maternal immunization.
bueno, dentro
So,
de un año, cuando
maybe in
nosotros
one
tengamos la
year when we
oportunidad
meet
de ver
again,
esto, si no hay una
if
obstetra
there's no obstetrician
mencionando
among the
eso, mire,
speakers,
la muchacha
please
dice no
tell
va.
me, okay, no, you won't be here anymore.
Y es muy importante crear
So
protocolos
it's important to create protocols,
porque
because
mire,
usually
es la
speaking, we do
vacunación de
vaccination
niños.
schedules
En mi
on
país se
children. In
usó
my
el
country,
protocolo
we
de
did
vacunación de
the
embarazadas en el 2012
protocol of
y
a
se
pregnant woman in
renovó
2012, and
nuevamente.
it was renewed
Llevamos
10
mucho
years
tiempo
after.
para
10
eso.
years is a lot when we talk about
Sí, así
immunization.
es. Bueno, sale un poco del contexto que estamos hablando,
Stepping
pero
out of the
aún la
context, I want to
vacuna
say
contra
that
virus
the
de papiloma humano yo creo que vacunamos
HPV
más que antes,
vaccine,
que los
we, the
mismos obstetras.
pediatricians, are the ones
Yo
who
he
vaccinate.
vacunado a
I
unas
have
dos
vaccinated a
chicas
lot
de
of
20,
girls
24
between 20 and
años
24 years of
y
age,
o si no, mujeres
or
albergue
fertile
jóvenes o cerca
women
de
in
eso.
fertile age.
Vamos a
And
utilizar la
the
vacuna en estos
obstetrician
meses
says,
porque
okay, the vaccine is there, and
no
this and
está
that.
embarazada,
So, can you imagine
porque
she's not
aunque
pregnant
ellos
when
tengan
we
mayor
expect that
incidencia,
they may have much more
porque
incidence with their
el
pregnant,
número de su
because
novio, madre, feto, es
that
altamente
couplet is
importante y
very
que más
important,
que eso
mother
conoce la
and fetus, and
vulnerabilidad de la
they
mujer
know
embarazada.
the vulnerability of the pregnant woman.
Si no hay más preguntas,
If
para
there are
yo
no
terminar
questions,
la
okay,
sesión
we will wrap
con
up this session. Thank you very much, and congratulations.